Neurology Quiz number 35. What are the mechanisms of action, uses, and side effects of valproic acid? Valproic acid is a short-chain branched fatty acid. Other forms include salts such as sodium valproate. Oral formulations of the medications are mainly in the form of divalproic sodium, a compound composed of equal parts of valproic acid and sodium valproate. It is a broad-spectrum AED with efficacy against all focal and generalized seizures, including absence and myoclonic seizures, and can be used as monotherapy or adjunctive therapy. It is one of the most effective medications for idiopathic generalized epilepsy with generalized tonic-clonic seizures, and should be considered as one of the drugs of first choice for men with generalized epilepsy. The intravenous formulation is used for management of status epilepticus. It is FDA approved for migraine prophylaxis and bipolar disorder. Its mechanism of action includes potentiation of GABA, blockade of T-type calcium channels, and inhibition of voltage-sensitive sodium channels. Oral bioavailability is more than 90%, but can be 10% lower for extended release formulations. Tmax is 3 to 7 hours for enteric coated tablets, while extended release formulations may have prolonged Tmax values. Time to steady state is 2 to 4 days. Protein binding is 90%. The free fraction is higher in newborns and elderly. Valproate is metabolized in the liver mainly by glucuronidation and oxidation. Valproic acid, glucuronide, and 3-oxovalproic acid are the most abundant metabolites. Less than 3% is excreted unchanged in the urine. Half-life is 12 to 16 hours in the absence of enzyme-inducing AEDs and 5 to 9 hours in the presence of such drugs. Valproate can increase plasma levels of lamotrigine, phenobarbital, ethosuximide, midazolam, and carbamazepine epoxide. It can increase free fraction of phenytoin by displacing it from its plasma protein binding site. Carbamazepine, phenobarbital, phenytoin topiramate, perampanel, ethosuximide can decrease its levels. It does not increase metabolism of oral contraceptives. It is available as delayed release or DR or enteric coated tablets of 125, 250, and 500 milligrams. These have a special coating which prevents the drug from dissolving early in the GI tract. The dose is 30 to 60 milligrams per kilogram per day, given 2 to 3 times a day. Treatment is initiated at 10 to 15 milligrams per kilogram and increased by 5 to 10 milligrams per kilogram every 7 days. It is also available as an extended release or ER formulation with tablets of 250 and 500 milligrams and 125 milligram sprinkle capsules, and these are designed to deliver the medication slowly over a 24-hour period. This is taken only once a day. ER formulation is preferred because it has better tolerability. Dose is 30 to 60 milligrams per kilogram per day. Given once a day. Treatment is initiated at 10 to 15 milligrams per kilogram and increased by 5 to 10 milligrams per kilogram every 7 days. The therapeutic level is 50 to 100 milligrams per liter. Common side effects, these include gastric irritation with anorexia, nausea and vomiting, and diarrhea. Dose-related tremor can be seen. If not relieved by dose reduction, propranolol can be tried. Other common side effects include lethargy, headache, dizziness, and ataxia. Also seen are alopecia, edema, and weight gain, and dose-related thrombocytopenia. Mild to moderate hyperammonemia is usually symptomatic and does not require intervention. The drug can also lead to decreased bone density with long-term use. Rare side effects include hepatotoxicity and liver failure, which can be fatal. Risk factors for hepatotoxicity are age less than 3 and polytherapy. Benign elevation of liver enzymes is common during valproate therapy, but fulminant hepatic failure is recognized by clinical features such as nausea, vomiting, and jaundice. Another rare but serious complication is acute hemorrhagic pancreatitis, characterized by vomiting and abdominal pain. A syndrome of reversible Parkinsonism, gait disorder, dementia, and brain atrophy has been described in the elderly. Endocrine effects include polycystic ovarian syndrome, hyperinsulinemia, and insulin resistance. Side effects in combination with other medications. Use of valproate and clonazepam may precipitate absence seizures and cause absence status. Combination with topiramate can cause hyperammonemic encephalopathy and coma related to increased levels of a toxic metabolite, 4-ENE valproate. In combination with cisplatin, there is higher risk of thrombocytopenia, neutropenia, and bone marrow suppression. Role of carnitine supplementation. Mild hyperammonemia is common in asymptomatic patients on chronic valproate treatment, and routine monitoring of ammonia levels is not warranted. Though high ammonia levels can be reduced with L-carnitine supplementation, there is no evidence that this is necessary or clinically beneficial. Consider L-carnitine supplementation in symptomatic valproate-associated hyperammonemia, those with secondary carnitine deficiency syndromes, and infants and young children taking valproic acid. Valproate has the highest rate of teratogenicity among currently available AEDs, with risk of malformation more than 30% at doses above 1100 milligrams per day. Use during the first trimester is associated with open neural tube defects such as cleft palate, craniosynostosis, ASD, and hypospadias. Children exposed to the medication in utero also show higher incidence of cognitive impairment as well as autism and autism spectrum disorder. It should therefore be avoided in women of childbearing potentials. Levels in the breast milk are 4 to 20% of maternal plasma levels. The medication should be avoided in patients with significant hepatic disease, those with a history of pancreatitis, patients with pre-existing thrombocytopenia or suspected mitochondrial disorder. It should also be used in caution in infants 2 years or younger, especially as polytherapy.